Hello friends, now I will be talking to you about cirrhosis of liver. Before I come to the clinical side of cirrhosis, let us learn some basic concept about the pathology of cirrhosis. What is the definition of cirrhosis of liver? The definition is that there is irreversible diffuse fibrosis in the liver, and as anything we get fibrosis is always irreversible, same thing here also. But what else is there? Regenerating nodules are made by the liver. You know it very well that liver has a amazing power of regeneration. Even if you remove a large part of liver by surgery, but the liver can still regenerate. So now let us focus on this regenerating nodules. What are these? What are the hallmark of this? First of all, when nodules are being made, it has been that simply indicate that there is lot of injury to hepatocytes. It itself is an indicator, and that is the thing which is prompting other cells to regenerate. Second point, but what is the nodule have? They do not have normal architecture. Is not there. That means whatever nodules are being made, they do not have normal architecture. Now normal architecture, let us learn what we get in a normal. This is the central venule. Here is the portal triad. Here are the sinus, these are the liver cells, hepatocytes, and here are the sinusoids, which have the blood vessels. Now this the portal triad has branch of hepatic artery, portal vein, and bile ductule. As you know, in the normal anatomy and physiology, blood from artery and vein goes toward, this is the central vein, it goes toward this central vein, but bile is the reverse flow. Bile moves away from the center, rather blood goes into the central vein. Now point to be noted, from the artery and venous, these both these blood go to hepatic sinusoids. So there is a mixing of the arterial and venous blood occurred in the normal sinusoid. So now as these nodules are regenerating, these nodules do not have this portal triad, rather even they don't even at times they don't make sinusoids. So what else is there? So they are not having the normal architecture. Well, Now these nodules are surrounded by fibrosis, which is the hallmark of the pathology of cirrhosis of liver. Now this fibrous tissue will compress other sinusoid and also portal triad, whatever are left, and that will lead to increase sinusoidal pressure. It will also lead to increase hydrostatic pressure. This is the basic pathology of what we get in the case of cirrhosis of liver. So finally the entire architecture is damaged, entire liver is fibrosed and regenerating nodules without any proper architecture. So now let us see what are the causes of cirrhosis of liver. Causes. Alcohol is the most common cause in the world as such, but especially in the Western world and the USA, alcohol is the most common cause, but in some eastern part of the world, then it is post necrotic is the most common cause. And this is due to hepatitis B and hepatitis C virus infection. Then it can occur due to autoimmune diseases, like primary biliary cirrhosis, autoimmune hepatitis. It can also occur due to certain metabolic diseases like hemochromatosis, Wilson disease, alpha-1 antitrypsin deficiency, galactosemia, primary sclerosing cholangitis, these are some of the important causes of cirrhosis of liver. So when we are suspecting a case of cirrhosis of liver because of clinical presentation, now what is the most accurate way to diagnose cirrhosis? Whatever cause it may be, diagnosis, most confirmatory for any type of cirrhosis is always liver biopsy. Liver biopsy is always the most confirmatory or most accurate test. The only exception to this is primary sclerosing cholangitis. This then we have this is a separate topic we will talk later on, but remember cirrhosis due to primary sclerosing is not confirmed by biopsy. This is an exception. Well, what are the general features which we will see in a case of cirrhosis of liver? Rather we get all the parameters what we see in chronic liver disease. So what features we see? feature of chronic liver disease. These include icterus, that is jaundice, pallor, bilateral parotid enlargement. Cirrhosis can be seen in some of the cases. Then spider nevi, Palmer erythema, Dupuytren contracture, flapping tremor. Flapping tremor. Please remember, we in this what we ask the patient to keep the hand like this, and you can see flap. Ascites, splenomegaly, caput medusae, gynecomastia, testicular atrophy, and alopecia. So these are the signs that we typically seen in all chronic liver disease, and since cirrhosis is one of the most common cause of chronic liver disease, so they are seen in most cases of cirrhosis of liver. Now let us talk about what are the complications of a case of cirrhosis of liver. Complication of cirrhosis of liver. First is the portal hypertension, and it has component are ascites, splenomegaly, GI bleed, upper GI bleed because of varices, gastropathy, that is congestive gastropathy. There are other complications also, but we will talk subsequently. First of all, we talk about portal hypertension and we talk about splenomegaly. this, you get massive splenomegaly. But the term massive means the spleen is so enlarged that it has come up to the umbilicus on clinical examination. And the one thing which it can lead to is hypersplenism. Hypersplenism. And due to this, it can lead to pancytopenia. Pancytopenia. Now, before I go to the next complication of ascites, I must tell you some other important causes of massive splenomegaly. This is a very important question you should know. So, you can say other causes of massive splenomegaly are, of course, portal hypertension, as I discussed just now. Number 2 is myeloproliferative disorders like PCV and CML. Then chronic malaria is a very important cause in those parts of the world where malaria is endemic. Similarly, we have a other condition called chronic Kala Azar. Then glycogen storage disease. They are some of the important causes of massive splenomegaly. So, now the second entity that we have is ascites. It is the definition of ascites. It is a collection of fluid in the peritoneal cavity. And if there is massive fluid in the ascites, then clinically you can detect by shifting dullness, in the abdomen, but very minimal quantity of ascites. This you can detect best by ultrasonography. Ultrasonography can detect as low as 50 to 100 ml of the fluid in the peritoneal cavity. But before we talk more about ascites, let's learn what is the pathophysiology of developing ascites in these patients. So, we talk about pathophysiology. Of ascites development. First of all, reduce albumin in the body. Why the albumin level is reduced? It's very obvious. It is in the liver, chronic liver disease is there, and you know very well, albumin is synthesized in the liver. Site of albumin synthesis is liver. So, as the liver is not making albumin, so that lead to reduced albumin will lead to reduce oncotic pressure, reduce oncotic pressure. So, oncotic pressure is reduced, that will lead to more hydrostatic pressure. The fluid will leak into third space. This is the blood vessel, fluid will leak because of increased hydrostatic pressure. Second reason why ascites occur is due to reduced aldosterone level. It is increase aldosterone level. Why increase aldosterone? First of all, normally aldosterone is metabolized in the liver. As the liver is not functioning properly, the aldosterone level remain high. That lead to a type of secondary hyperaldosteronism. Other reason why secondary hyperaldosteronism occur, because as I told you, fluid is getting leaked out into the third space. So that lead to reduce intravascular volume. Point to be noted, although total body fluid is increased, but it is in the third space, but there is reduced intravascular volume, that lead to reduce renal blood flow, and that lead to increase aldosterone. So this is a how another reason why secondary hyperaldosteronism occur. So that's why if you want that a body should lose out the fluid, the best diuretic will be always aldosterone antagonist. Now your concepts are very clear ki why we will using spironolactone in this case for the treatment of ascites. So if you have to treat the ascites, the treatment plan is like this. We will like to do paracentesis. That means we will like to aspirate the fluid to see how much cells are there and how much proteins are there. Now, what are the indication of paracentesis? That means you are tapping the ascitic fluid. Patient coming to you for the first time patient coming to you, you tap it, but if this diagnosis is confirmed, then you need not do the repeat tapping every time. Second time, if patient develop fever with abdominal tenderness, you must aspirate the fluid because perhaps patient has developed spontaneous bacterial peritonitis. So once you are doing tapping for the first time, what is the important information you will get? The most important information is, of course, you will come to know how much proteins are there. In this we get transudate. We get it. But even more than the transudate, what is important is serum SAC. That stands for serum ascites albumin gradient. In this, how we calculate SAG? Serum albumin minus ascitic fluid albumin level. Normal is always less than 1.7 gram percent. Now, how to move around? So, let us talk more about SAG. SAAG. Let us see what are the other things that we will come to know from this information. And we also talk about serum albumin. Serum albumin less than 2.5 gram percent, more than 2.5 gram percent, and less than 1.1, more than 1.1 gram percent is there. Okay. So, if it is more than 1.1 gram and it is less than 1.1 gram, it is nephrotic syndrome, and other is nephrotic syndrome, and other thing where we have is cancers, tuberculosis. But if it is more than 1, this is cirrhosis of liver, and in exudate it is right heart failure, Budd-Chiari syndrome, constrictive pericarditis, non-cirrhotic portal fibrosis. This is a very, very important chart to be remembered regarding SAG. Okay. So, we got the reason that in this you are getting a transudate and we are getting all the information. How to manage this case of ascites? Management of ascites shall be, first of all, treatment. First of all, low salt, low water intake, patient daily weight checking is mandatory. If the patient has reduced water and salt intake, usually patient loses the weight by about 500 grams per day. Of course, we also use diuretics. Drug of choice is anything which is aldosterone antagonist. That's why we always use spironolactone, or we can use the new drug eplerenone. Eplerenone is again a newer types of aldosterone antagonist, just like spironolactone, but it has one advantage: it does not lead to gynecomastia. Then if there is massive ascites is there, then we can even tap out the fluid, but it should not be done too vigorously. Rather, many authorities, they do not even advise for this, but books do mention about, you can tap out about 1 to 1.5 liter of fluid per day. Otherwise, we can go for tips, that is transjugular intrahepatic portosystemic shunt. Transjugular intrahepatic portocaval shunt. But in the last but not least, what we talk about always surgery, surgeon do portocaval shunt. Now, what problem can happen in ascites? One important problem what can happen in ascites is spontaneous bacterial peritonitis. When we suspect SBP, if the patient, ascitic, known case of ascites, if he develops fever, abdominal tenderness, especially rebound tenderness, that is highly suggestive of spontaneous bacterial peritonitis. Now, how to do the diagnosis? Beyond doubt, ascitic fluid culture is the most confirmatory, but it becomes positive only in few cases. Investigation, to be more precise, gram stain of the ascitic fluid is always negative. Why negative? Because it is in the low dose, the organisms are in very low concentration. Why the concentration is so low in this patient? For that, we got to know the basic pathogenesis of this condition. Remember, spontaneous bacterial peritonitis is a infection of the ascitic fluid without any known source of infection. We don't know what the source of infection is there. That's why the usual organisms are very low concentration is there. Due to same reason, culture sensitivity may or may not be positive, but beyond doubt, this is the most best diagnostic tool is this. And now, what are the usual organisms which can involve in this? E. coli are there. Anaerobic bacteria are uncommon. Other thing, of course, this is the most common organism. The other organisms are what we call as streptococci or other enterococci. So, as I was telling you, they may or may not be able to detect even by culture. Then what is the single best initial test? You look for the ascitic fluid. If it contain more than 250 neutrophils per ml is highly suggestive of spontaneous bacterial peritonitis. This is highly suggestive. Now you need to treat the patient in intensive care because mortality is as high as 70%. So you have to treat by treatment is by giving third generation cephalosporin like ceftriaxone, recurrence is very common. In fact, a patient of cirrhosis of liver having ascites, the patient needs lifelong prophylaxis. So, what drug we use for prophylaxis? For prophylaxis, we can use ciprofloxacin, norfloxacin, or trimethoprim sulfamethoxazole combination, so called Septron. These are the few drugs that we use for prophylaxis, but it is to be given lifelong prophylaxis because recurrence is very common and mortality is very, very high. Thank you very much.